start the session. So, ladies and gentlemen, it's an honor to welcome you all to the first meeting of the Egyptian Scientific Society for Sleep Medicine and Research, الجمعية المصرية العلمية لطب وأبحاث النوم. And don't ask me why the name is so long. We offered them 12 names, and this is the one they chose. So we have a long name. On behalf of the society, I'd like to thank the Egyptian Scientific Bronchology Society for giving us the opportunity to have this meeting in coordination with their very prestigious yearly meeting. And my special thanks to Professor Tariq Safwat, who was constantly encouraging this endeavor. I also thank the faculty who some have traveled a long way to come and join us and graciously accepted our invitation and put us in a very busy schedule. Professor Safwan Badr came all the way from Detroit, Professor Alaa Gindi and Mr. Alaa Gindi came from Florida, Professor Luigi Ferini-Strambi came all the way from Milan, Italy, and also all our colleagues who came from all different governments in Egypt, from Alexandria to Asyut. All of them graciously accepted our invitation. And the most important, of course, I thank the audience. I see the audience are not all there, but hopefully we'll get many more. I definitely thank them for registering, for coming, as they really make it worthwhile, all the effort spent in that. Having mentioned the effort, I also mentioned the organizing committee, Professor Iman Hassan, Professor Ahmed al-Masri, and Professor Lamia Afifi, who unfortunately could not join us today as she is in the US. And last but not least, Dr. Ahmed Gharib, who definitely spent an enormous and tremendous time and energy to put this meeting together and have it run. We also thank the industry for their extremely valuable support, and the conference organizing bureau, COB, Mr. Islam Shalabi, they are all responsible for all the logistics. So if anything goes wrong in this meeting, it's their fault. We hope you enjoy the meeting and welcome to sunny, peaceful, glorious city of 1,000 minarets. Thank you very much. Professor Tariq Safwat will not be here as he was in 2 sessions. He's our host. He is the force behind all that, and I welcome.
Good morning, ladies and gentlemen, Mr. Chairman, Suzanne. Shahira, thank you so much for your nice words. It's a pleasure having you with us, and I hope this meeting will be nice, the conference will be good, and I believe, I'm very optimistic that the workshop will be excellent. It's the first time that we have this integrated workshop with the pulmonologist and the neuropsychiatrist. I believe it's going to be very fruitful. Thank you for being here, and have a good morning and enjoy the place. I know it was maybe quite difficult to reach the Meridian, and people were confused about the Meridian, Laruba, and the Meridian Airport. So I think it's our first time to have this meeting in this place, and I'm optimistic it's going to be fine. Thank you very much, and have a nice day and a very fruitful workshop. Thank you very much.
Bismillah ar-Rahman ar-Rahim. Again, I congratulate Professor Shahira and for the first scientific meeting for the Egyptian Scientific Society of Sleep, Medicine and Research. At last, the dream came true after how many years? 10 years? 13 years. I also welcome Professor Suzanne Salama as my Lady and Professor Tariq Asad of me. And we'll start our first distinguished speaker, Professor Safwan Badr, and he will speak about sleep disordered breathing, opportunities and challenges. Professor Safwan.
Good morning. Thank you for inviting me, and Professor Loza, thank you very much for inviting me to sunny Cairo. I've wanted to be here for a long time, so this is also a dream come true for me. Well, I'm going to talk about a few things related to sleep apnea, but I figured maybe one way to start is bring a few things about sleep itself, because I think we're moving now from sleep as diseases and disorders to sleep as health and part of health. And I'd like to start introducing this concept. So one common joke in the sleep field, because people ask me, what does sleep do? What's the function of sleep? Well, we know that if you don't sleep, you don't live. Okay? I think Umar al-Khayyam was wrong. I don't think he was right when he said, فَمَا أَطَالَ النَّوْمُ عُمْرًا. I think that was incorrect. We know now if you don't sleep, you don't live, you die. But why and how is what we don't know. That's really the billion-dollar question. And one joke in the sleep field is that if sleep doesn't serve an absolutely vital function, then it's the biggest mistake the evolutionary process ever made. Because otherwise, 1/3 of our life is going towards sleep. But there is a whole lot to tell us it's actually critical. And I'm going to show you some data that is relevant. Now, I have to apologize, my presentation doesn't have the Mediterranean sleep schedule in mind, which has a siesta and a break in the middle, because it hasn't been studied as well, but maybe some other people can elaborate on it. So now we're changing the terminology to something called sleep deficiency. And sleep deficiency is not enough sleep, which is a lot of people are sleep deprived, poor sleep quality, and this is where sleep apnea comes in the picture, anything that fragments the sleep. I guess in principle, if you have a snoring spouse, you also have sleep fragmentation. It goes both ways. And circadian misalignment. Shift worker is an example of this, or people who have circadian rhythm disorder. Now there are primary sleep disorders such as narcolepsy. Now, these obviously statistics from the US. I suspect these numbers will probably be translated across continents and across nations, but this may be an area where local statistics are needed. 50 to 70 million in the US, so basically 1 out of 4 people have some type of sleep disorder. I suspect this is probably across the world. 70% of high school students, now then this may be more US based because of the school timing, start timing. I don't think it's the same everywhere, but again, teenagers are usually sleep deficient. Shift work, that number is probably about the same everywhere. 20% of the population are involved in some kind of shift work, whether it's hospitals, factories, airports. In the US now, sleep health has been declared as a priority. It's a national priority for what the NIH call the Healthy People 2020. But again, we really need data from different countries. And I actually tried to do some literature search on data in Egypt. I couldn't find anything through PubMed. Maybe someone could enlighten me and direct me, because I think such data are very important. Now, I was blaming Umar al-Khayyam, but I don't think he gets blamed for the modern problem. I think the modern problem with sleep, this man has to be blamed. His name is Thomas Edison. We all credit Thomas Edison for a whole lot of things. And he's the one who invented the light bulb, which is one of the reasons why we developed some sleep deficiency. But he also said, which was really problematic, that sleep is he said that sleep is a criminal waste of time. I mean, these were exactly Thomas Edison's world. So burning the candle on both ends, staying up late became a value. I guess that's Wall Street, that's all the students who are studying, everybody wants to stay up late. But it's actually not a value. There is enough evidence to say that if we are sleep deprived, we will become grumpy, accident prone, and obese. These are three important things. And now that links us to a whole lot of other issues. So let's start with drowsy driving. 250,000 drivers in the US fall asleep at the wheel daily. And I think this is also an area where we need comparative literature. We need studies from different countries, how common this issue is. There is a crash every 25 seconds. There is a fatality every 70 minutes. So pretty much, at least in the US, by the time I finish my presentation and have a cup of coffee, one person has been killed from a fatality. And I don't have any reason to believe that these numbers vary across countries. I think these numbers are probably the same. Now, one of the things that are also important is what sleep deprivation does. So typically, if I can't fall asleep and I'm kind of insomnia, can wake up in the morning or get up in the morning without getting enough sleep, I've never said, boy, I'm really craving a lettuce or a healthy salad. People tend to crave carbohydrates. People will like to eat something sweet, something fattening, and that's actually biologically driven and biologically determined. Sleep deprivation affects the relationship between leptin and ghrelin. So leptin on the top and ghrelin is on the bottom. Point to it. This is the leptin, this is the ghrelin. Leptin decreases as this is the satiety hormone. So people actually become hungrier and they crave carbohydrates. The important issue though is, look at the BMI as the weight, the body mass index. Individuals who sleep 7 to 8 hours have actually the best body weight, the lower BMI. So there's some relationship between sleep and weight. Now this is not something that we knew up until a few years back, but now there's enough literature to emphasize that point. This is the biggest thing, sleepiness and sleep deprivation. Every industrial accident in the industrialized world, at least that's been studied, has been linked to sleep deprivation. Example is the shuttle disaster. Everyone knows about the space shuttle. I suspect every one of you here in this room remember exactly where they were standing when that thing happened, or sitting or sleeping. And this is what the commission showed. This is the Presidential Commission on the Accident. The willingness of NASA employees to work excessive hours, while admirable, raises serious questions when it jeopardizes job performance, particularly when critical management decisions are at stake. And this is actually the same thing applies to Chernobyl, the same thing applied to the Exxon Valdez. So you talk about some of the very large accidents that killed people or damaged property or damaged the environment, and you will find that sleep deprivation was part of that. Now this is actually the biggest issue, is this. It is the whole survival issue. Now there is we now know that there is some U-shaped relationship. Cross-sectional data, 7 to 8 hours of sleep, the best survival, the highest longevity. Okay. Now you may ask, well, what about the long sleepers? They look like they don't live as long either. But the issue with the long sleepers may be just an association. It's a perception because they have other conditions. So we get into the snoring. When I was a medical student, sleep disorder breathing wasn't even known as a term. People at that time were talking about the Pickwickian syndrome, and that's about all that was discussed. There was no medical terms even for it. But at that time, we thought that snoring was just a benign acoustic phenomenon, something to make fun of my uncle when he snores, and something for family dinners. And now, what we know is that snoring, actually the airway is partially blocked. There's actually narrowing of the airway. So snoring, from this standpoint, is similar to fever for somebody with an infection. And the way to look at it is that this is an upper airway of a healthy individual. This is the uvula, and the airway is wide open. A person who snores, there's enough narrowing that you cause fluttering. It's like how the wind affects the sail and create that vibration. And when this thing narrows completely, now there's obstructive apnea, the airway is closed. And this is what things look like for those of you who are not in sleep medicine, aren't used on looking at looking at these things. This is what a segment of what we call a polysomnogram, which is another word sleep study. This has eye movement, chin. These are 2 EEG channels, leg. This is flow. This is the sum of the signals. This is effort. And what happened here, you see there is a period where there is absolutely no flow. It's a straight line. That's an apnea. And this apnea is happening with continued effort. And in fact, the rib cage and the abdomen are moving in opposite direction. That's a complete upper airway obstruction. If you look at desaturation, it's decreasing. And then there's some arousal here. There's awakening from sleep. So 2 things happen. You drop your oxygen level, because actually you're under asphyxic condition, and then you have an arousal from sleep that fragments your sleep and your time. Now this is more of a physiologic way to look at this. This is not a typical clinical study. This is a segment from a research study in the Wisconsin Sleep Cohort study. This is the flow, esophageal pressure, which is a reflection of the pleural pressure. So when we generate an effort, you will see a negative pressure deflection. This is the blood pressure on a beat-by-beat basis. It's called a feet-press device. And this is the sympathetic activity. This is actually a needle inserted in the leg, the cranial nerve. This is an event here. This is the person is breathing. There's a flow, an apnea, another apnea, another apnea. Look what's happening to the esophageal pressure. There's a significant increase in effort without flow, and that's excessive work. Look what's happening to the oxygen level. It's dropping to 80%. Now, if we're monitoring a patient in the OR or on the floor or in the ICU and they drop their saturation to 80%, that's a very alarming thing. And somehow we accept this many times in sleep for years. Look what's happening to the blood pressure. There are rises in blood pressure with every one of these events. And this is the sympathetic activity also rising. So a given apnea causes increase in blood pressure, drop in oxygen level, increased sympathetic activity. Is really an equivalent. It's somebody waking you up, choking you, and making you mad all at the same time. And it's happening repeatedly throughout the night. Now, this is the typical profile we think of in sleep apnea. We think of a male. We think of a very obese male with a big belly. It's actually that's no longer the case. Now we know that sleep apnea can affect anyone. And I have patients who are marathon runners, perfectly healthy and young, who have the condition. So we shouldn't start with the weight. This is what a typical compressed study would look like. We call this a hypnogram, where this is simply the whole night. And this is what's happening to the oxygen level up and down throughout the night. Now, at this point, nasal CPAP was added. And you can see that as the level was increased, everything normalized. And this is what the oxygen level looks like. These are the events, and now there are no events. So sleep apnea is perfectly treatable, and treatable with nasal CPAP in a majority of patients. So let's talk about some of the clinical aspects. Snoring and excessive daytime sleepiness. So snoring is a fairly easy one to ask, although I have to admit, when I inquire about the symptom in different Arabic-speaking populations in Detroit, I have difficulty getting it because it actually does vary. So there is a local way of expressing it that is not the same, and it seems to vary from region to region within country. This is one of my challenges. Excessive daytime sleepiness, that's another symptom that I find to be very hard to capture. And there also may be a cultural element to it, and I suspect Egyptian sleep physicians will know how to take that history a lot better than I do. But it's many times patients tell you, I'm not sleepy, and then when you dig down, only when I'm tired. Well, that was my question. And I start asking, if you're watching TV, so we have one of the instruments called the Epworth Sleepiness Scale. I suspect it is translated into Arabic and it's validated. And that one actually seems to work very well because it gets me past that original point. Although I have patients who are too sleepy to recognize that they're sleepy. They're falling asleep in front of me and they're marking it negative entirely. And I don't know if that's the same in your patients. Witnessed apnea is actually a very powerful sign. Multiple nocturnal arousals, headache, and reflux. Headache, reflux, nocturia are actually significant symptoms that are often not asked. I'm going to get some epidemiology data, but I think some of it might be outdated, but it's also relevant. And as we look at different countries with different obesity rates. This is the Wisconsin sleep cohort study, which I was involved in, and that was the very first large epidemiologic study of sleep apnea in a community. These were not referred. This is Dane County, Wisconsin. It's all employed, all have good insurance, and they have a whole continuum of conditions. So among men, the total was 24%, and among women was 9%. So 5 events per hour of sleep, 1 out of every 4 men had the condition. I mean, this is a scary number. Among the women, it was about 9%. If we narrow it down to snoring, snorers 1/3 of the men. So 1 out of 3 men who snore regularly. So simply asking the spouse, does your husband snore every night and drive you crazy with his snoring? If the answer is yes, 1 out of 3 have sleep apnea. Now, this is not the condition. This is the laboratory phenomenon. If you bring this to a condition, which is combining it with a symptom, it's 2% of the women and 4% of the men. Still a large number. This is a significant number of the population. And I would actually love to see epidemiologic data from other countries, because these things are actually there is some variation in it. These data were also corroborated by another large study from Hershey, Pennsylvania. And this is what they found. This is about almost 1741. And using the syndrome definition is also 1.5 and 4%. So pretty much the numbers are consistent. There's one problem, and this is all was done in the previous millennium. Now, there is a relationship now we know with obesity. So this is also from the Wisconsin sleep cohort study. As the weight is increased, the condition is increased. So if you take individuals who did not have sleep apnea at a given point, follow them for 4 years or 8 years, and they've increased their body weight by 10%. So you have somebody whose weight is 70 kilograms today. 5 years later, they're 77 kilograms. They could go from not having the disease to having the disease just by gaining weight. So weight gain is pretty much the major risk factor. So why is this relevant? Well, I took that out because the statistics aren't applied to Egypt. I don't know what the obesity rates are, how they're changing over the past 10 years. So obesity rates in the US are probably some of the worst. So the numbers in the US today are probably 2 or 3 times the number that was in these studies. I don't think obesity rates here are anywhere near what they are in the US. And in that case, it's really critical to have local epidemiologic data. Another risk factor is menopause for women. So premenopausal women have much lower risk of sleep disorder breathing. But as menopause is reached, you see that the proportion of individuals, women with sleep disorder breathing, increases substantially. So that's another risk factor. So let's look at associations. Most patients with sleep apnea aren't really seen by sleep physicians first. They're seen by primary care physicians. So we need to kind of broaden the appeal of when we actually suspect the condition. So obesity, heart failure, resistant hypertension, reflux, diabetes, and chronic kidney disease. These are all conditions that should alert us to the possibility of sleep apnea. Oh, this is the obesity one that we didn't include. So when that first study was published, I'm just going to show you my state of Michigan, my lovely state of Michigan. And this is the obesity rate in 1993. Okay, 15 to 19% were above. Now this is the year 1999, and now more than 20% are obese. This is the year 2010, and more than 30% of the population of my lovely state are obese. And you can see most of the US now is red. So, and that is, there are now some reanalysis of all data that literally would double or triple the prevalence of sleep apnea. Hypertension, one of the biggest associations, things that are reversible with sleep apnea is hypertension. So this is also from the Wisconsin Sleep Cohort Study. Those who have more than 15 events per hour of sleep, after you adjust for everything, this is the gray bars, more than double. So if you have sleep apnea, you double your risk of hypertension. Plain and simple. That's actually an important number to remember. Clinically significant sleep apnea double the risk of hypertension. Diabetes. That's another one that is now becoming a major issue. And I don't know what the prevalence of type 2 diabetes in Egypt is, but in the US, this prevalence is increasing substantially. These are multiple, this is heart failure, not diabetes. I'll talk about diabetes next. This is heart failure. It's another one that is 1 out of 2 patients who have heart failure is likely to have sleep apnea. So now we're talking blood pressure doubles the risk, heart failure 1 out of 2. It's more in men, but it's also in women. So systolic heart failure, we must think of sleep apnea. It's almost a strong association. Reflux. It's another association that we see between sleep apnea. The question is, why reflux? Well, remember the slide I showed you with the occluded airway and the negative pressure in the esophagus? Well, that negative pressure eventually will overcome the ability of the sphincter, the gastroesophageal sphincter, and acid will make it into the esophagus. So when I ask my patients, I always ask about reflux. It's actually a very, very significant symptom. And by the way, patients who are adherent to their CPAP, who are using their CPAP, reflux will improve. And since patients who are not going to tell me the truth, they tell me they're using their machine, reflux is a benign way to ask them because they're not suspecting that these two are related. This is the reflux before and after CPAP. So this is a very, very strong association between reflux and sleep apnea. Type 2 diabetes, that's the one. And this is the adjusted hemoglobin A1C. Bottom line is about 70% of patients with type 2 diabetes have sleep apnea. Actually, in the United States, the American Academy of Sleep Medicine, that was one of their PR campaigns last year, is if you have type 2 diabetes, think sleep apnea. And it actually seems to be independent even of obesity. So type 2 diabetes is a strong association. And you may ask why? Well, in sleep apnea, you have what's called chronic intermittent hypoxia. You have repeatedly causing deoxygenation, reoxygenation, and there's strong evidence that induces insulin resistance. So I think this is one of these associations. And now the picture gets a little clearer. This is what a typical internist sees: high blood pressure, diabetes, heart failure, reflux. These are all conditions that an internist anywhere in the world sees and takes care of, and they need to think of sleep apnea. Another one now is end-stage renal disease, which is not, people don't think of end-stage renal disease when they think sleep apnea. But this is the prevalence of sleep apnea in ESRD. Pretty significant, more than 50%. Now, interestingly enough, this one I was able to find Egyptian data, which is fairly recently published. And this is survey instrument. And it's fascinating. It's not polysomnogram, survey instrument based on self-diagnosis. Insomnia, restless leg, and sleep apnea. So this is even without a polysomnogram. 1 out of 5 patients who have end-stage renal disease reported that they have sleep apnea. So this is pretty significant. if it's just simply there are quite a few who aren't being diagnosed that they have sleep apnea. And this also, actually, this is a very interesting study in my mind because it's putting together all the combination of sleep disorders. Patients with sleep apnea don't only have sleep apnea. A large number of my patients who present to me are also have insomnia because one of the things they develop with sleep fragmentation is poor sleep hygiene, and they turn the TV on, and after a while they develop insomnia. So this is an interesting combination. It's really and that's why I like this study. It's very holistic. It's putting all the different conditions that could be the common ones in one. So patients with end-stage renal disease are very likely to have sleep apnea. The diagnosis, clinical features, questionnaires, laboratory testing, and out-of-center testing. And I would love to know what the pattern of practice in Egypt is about making the diagnosis, because that's becoming a hard and costly endeavor. This is one thing that is, well, only people who are from the US would recognize this feature, people who don't know Jay Leno. But the idea is that this is a big chin that moves too far forward, is a wide open airway. There's retronathia is actually a very major anatomic landmark, and when you see retronathia, that means the airway is small. It's a fairly common observation, and I see it quite a bit. Another clinical sign we use, which is called the malapati, which is we shamelessly stole this from the anesthesiologist. They use it for intubation, and when you can't even see the back of the throat, that's class 4. Now, none of these signs are specific. Absence of these signs doesn't exclude the disease, but when you see it, it's actually convincing for the patient more than anything else. The one that I really like this is from the Wisconsin Sleep Cohort Study, is neck circumference. So usually, we know that for a given body weight, men have larger necks than women. And there's no reason to suspect that this varies anywhere around the world. So for example, and that's exactly for every BMI. So men with 43 centimeter, which is not a very large neck, I mean, quite a few men have this neck circumference, 31% will have sleep apnea. So I'm always tempted of a business idea of go to a department store where they sell men's shirts, and every large shirt stick a referral to a sleep center. I could take your center and refer all the patients, because 1 out of 3, simply having a neck circumference over 43 centimeter means 31% chance of sleep apnea. 3 out of 10, pretty high. The women have a totally different distribution, and neck circumference is smaller, so it's only about 14%. Consequences: hypoxia, arrhythmia, ischemia. Hypoxia here is the intermittent hypoxia, it's not continuous. And consequences, cognitive consequences, systemic hypertension, cardiovascular disease, and mortality. This is really the important one. We've waited for these data for years. Because one of the arguments is like, big deal. The patient is sleepy, but are they going to die fast? Is it really a fatal disease? And there are 2 studies that now answer this question. One is the Wisconsin Sleep Cohort Study, which started in 1988. And it took, obviously, 18 years to get 18-year data. And this is the results. So depending AHI below 5 and AHI more than 30, clearly the survival rate is strongly affected. You may not see it very much in the beginning, but look at the rapid decline afterwards. So there is no doubt now that untreated significant sleep apnea contributes to excess mortality. I mean, that is now, I don't think there's any debate about it. This is now enters among the diseases that could affect survival. And 3-fold increase in all-cause mortality. Okay? And when they've actually excluded patients who reported using CPAP, the number increased. So clearly, untreated sleep apnea is potentially fatal. Another one is even a larger study. This is called the Sleep Heart Health Study, which is of multiple centers in the United States. some on the East Coast, some on the West Coast, very diverse populations, some rural, different racial composition. So it's almost representative of the world's population because it has just about every population in the United States. And this is what they found. Look at the red one compared to the dotted. So clearly, and this is over a 10-year period. So over a 10-year period, untreated severe sleep apnea means excess mortality, which means this is now a disease that we must treat. And that's actually our biggest challenge. This is where we get to this issue that makes it a little bit more difficult. Where do we draw the line for treatments? Because we know the more than 30 is excess mortality. We know less than 5 is the norm. What's in between? Why am I showing you these two? Well, the reason is because we use, for the most part, a blood pressure analogy when we treat sleep apnea. So we're liberating our patients, the Statue of Liberty, from a condition. The problem is that the analogy isn't completely perfect. So blood pressure, the way blood pressure is measured in Cairo, in San Francisco, in Shanghai is exactly the same. The devices are the same. The units are the same. The method has been validated and used for 100 years. Okay? How we diagnose sleep apnea in the lab on this side of the street, on the lab that side of the street may not be the same. The instruments aren't the same. The sensors may be slightly different. The definitions may be slightly different. The oximeters may be slightly different. So comparing numbers isn't as easy. And that's why when we look normal versus 30, things are clear, but what's in between requires a lot of clinical judgment and becomes a clinician's decision. This is a picture of the very first CPAP machine, courtesy of Dr. Sankuna, who got it from Dr. Colin Sullivan, okay? And this is literally a vacuum cleaner inverted. This is a vacuum cleaner pipe. Everything was put together with tape and everything. It's absolutely fascinating. Now, in the old days, they used to make the masks for every patient, okay? Individually. They're individualized, they're custom, like what dentists would do. I mean, it looks to me like there are quite a few Arab men, I see mustaches here, that then have it. And clearly it's fitting and all of that. Now, obviously, the masks are pre-manufactured and allegedly fit, but this is one of the problems we have. Consequences. Are we going to make any difference when we take our patients? Car accidents. Look at this. There is a significant change in car accident rate if patients are treated. So treatment of sleep apnea has an important effect on function. What about blood pressure? Look at the number of studies that were done. This is what's called a forest diagram. If you're on this side, it's good. On this side, it's not. And this is the line of identity in the middle. When you average all of the studies, there is a slight decrease in systolic blood pressure in treated patients. Now, the cynic in me will look and say, well, it's only a few millimeters of mercury. What are you talking about? Why is that significant? Apparently, epidemiologists would tell me that if you have studies with 10,000 people and you see 2 millimeter of mercury difference, that's huge. That is actually very meaningful. It varies among individuals, but actually in that kind of study, that's very meaningful. And you see that the aggregate of the data will indicate that. This is now also the same thing, net change in systolic. And this is now the mean blood pressure. And again, the number of studies is smaller, but again, the direction is exactly the same. So now we know treatment of sleep apnea improves performance in terms of car accident and in terms of blood pressure. Well, this is the event-free survival in patients with heart disease as well, and you clearly see that there is an improvement. And I think this is exactly the same one. So there's evidence that with mild SDB with no CBD, there is clearly a difference. Now, I don't know about your patients in terms of PAP use, CPAP use. this is one of our biggest issues. The vast majority of patients don't tell us the truth when they talk about CPAP use. When we look at the data objectively, their use is less. These things are supplied in the United States by what's called durable medical equipment, and many times they tell them, oh, all you have to use it is 4 hours and you're okay. And the reason is that's what the payers in the US demand, 4 hours as a minimum use. Anything less than that, they take the machine from them. More than that, they keep it. So the question is, does it really make a difference? Because I tell my patients, I want them to use it every time they're asleep. And the question, does it truly make a difference? Well, this is a study by Dr. Terry Weaver. At that time she was in Philadelphia, now she's in the University of Illinois. And they looked at 3 indices. One is multiple sleep latency test, which is a sleepiness test, an objective in-lab sleepiness test. This is the Epworth Sleepiness Scale, which we all use. And this is something called the FOSQ, Functional Outcome of Sleep Quality of Life. It's a quality of life, sleep apnea specific that she developed. And these are the hours of use, and these are how things are changing. So look at the MSLT, and you see that there is an increase and continues to increase 4 and even 6 and even to the very end. Look at the FOSQ, the quality of life continues to increase, and this is the ESS. The only one that seems to level off clearly, the more you use it, the better off you are. So I tell my patients, every time they're asleep, I want them to be using the meds. I tell them they're either upright without CPAP, anytime they're supine and sleeping, I want them to be using their CPAP. And it's a hard message to tell patients because for some reason, it takes a while to get that idea. And that is really our biggest barrier, is that the treatment requires an additional effort on part of the patient. Now, we sleep docs tend to blame our patients and say, well, they're not using their CPAP. But interestingly enough, if you look at the data of chronic therapy of any kind, including antihypertensive, including supplemental oxygen, including dialysis, patients miss about 1/3 of their dialysis sessions. So chronic disease is a problem, and treatment and how we motivate our patients is actually a challenge. This is one of our biggest management challenges. So I want to summarize by bringing us back to the whole idea of wellness. This is what we call a 3-legged stool. We've always talked about nutrition. We want people to eat healthy, lower their cholesterol, don't eat fat, eat high fiber. Okay? We always encourage people to exercise. This is what every one of us here as a clinician does. Now we need to add to it sleep. Okay? We need to tell patients that getting enough sleep is not a waste of time, it's actually good for them. It may help their weight loss, it helps their cardiovascular risk. It's part of treating any sleep disorder, including sleep apnea. Sleep is divine. I do remember now what my grandmother used to say, no sultan, okay? And I think this is probably one example where we actually have to repeat that. So I've actually translated this and I tell my patients, sleep reigns supreme. We really need to think of it that way. This is not a waste of time. This is not a wasted effort. This is part of making us who we are. So I want you to remember a few things: obesity, heart failure, resistant hypertension, gastroesophageal reflux, diabetes, and chronic kidney disease. Anyone who has any of these conditions is a very high likelihood to have sleep disorder breathing. We don't need to wait for them to report to us sleepiness because patients adjust. We don't need for their spouses to complain about their snoring because that's beyond our control. But if we have these are good markers, then we can start the conversation. We can ask them, we can be a little bit more proactive. So sleep apnea, it runs in families sometimes because people eat the same food. So this is a husband and wife. They both of them have sleep apnea and it's the only way they can get any sleep. This is an old picture. I'm actually trying to get some of my own couple patients to get me newer ones. With that, thank you. I'll end here. Thank you for inviting me. And I'll have
especially the disorder with diabetes, hypertension, and renal failure. We can leave the question to the end of the session. Congratulations for Professor Shahira Loza for this scientific session, and this is the first conference of the Egyptian Scientific Society of Sleep Medicine and Research since 13 years. She's a hard worker in these topics, and we congratulate her for this first event. Now I can invite Professor Mustafa Shamsi, I think he's not here. We can invite the couples of Alex, Professor Mahmoud Ibrahim and Professor Nashwa to talk about the cardiovascular complications of obstructive sleep apnea and its effect of treatment. Thank you.
Bismillahirrahmanirrahim. I'm very delighted to be in this meeting, and I'm very grateful for the organizers and for the Professor Shahira Loza for starting this association between people who are very interested in sleep medicine and creating such a society which will all try to something to collect us all in Egypt and everywhere who are interested in sleep medicine, particularly in Egypt here, because societies are everywhere in sleep medicine around the world, but we are lacking this. So I congratulate Professor Shahira Loza for taking such a forward step. And I hope this society will take its position in Egypt, inshallah, and in the world, inshallah. Thank you for inviting me, and it's a pleasure to be here between you. I'm just going to talk about some of the cardiovascular complications, and some of this is a repetition for what Professor Van Baden has said, and it's made it much easier for me to talk. Now this is sleep apnea, and sleep apnea, as you heard, it's had several complications in everybody's system, and we need to have the awareness of if this is the primary thing that society could do is make sleep apnea, that physicians be aware about what sleep apnea. And we still have this difficulty, and you all know that even physicians don't know what sleep apnea. Now this is the first posthumous papers of Charles Dickens, and this is the first description of the Quitchen syndrome of a patient with sleep apnea. Joe, the fat boy, who was eating and sleeping everywhere. Now, prevalence of sleep apnea, as you all know, is very prevalent. 24% of men and 9% of women. And women, as being pointed in the previous talk, if they go to the postmenopausal, they start to have an equal rate to the men as having sleep apnea. So the problem of menopause, whenever it started, even if it's delayed, it's a protective premenopausal for patients, females who get sleep apnea. Now, the pathophysiology of sleep apnea, as you just heard, is obstruction, increases sweaty effort, causes fragmented sleep, and this will cause the hypersomnolence, the release of sympathetic hormones, and this will all cause all the disturbance of the cardiovascular system, and intermittent hypoxemia, which again has a deleterious effect on all the body system. Now, sleep apnea will affect the quality of the life, will cause morbidity and mortality, as we just heard. Obstructive sleep apnea predisposes the factor for congestive heart failure and antifibrillation or arrhythmia, which is different from central sleep apnea, which is manifestation of the sleep of the heart disease and the cardiovascular manifestation, as stroke and heart failure and others. So this is the quality of life, which is disturbed. A patient who is disturbed, his quality of life is very disturbed. And we have many stories we all know about how disturbing this for the quality of life. Again, so this is the effect of obstructive sleep apnea on the motor vehicle accident, as we showed in meta-analysis. Many studies showing how this affects the car accidents. Now, unfortunately, and maybe this is an old paper from 1997, that the detection rate of this sleep apnea is very low. However, I think around here, in other parts of the world, there's still that the assessment of the finding of sleep apnea patient is still much behind. And we're still looking at the top of the iceberg, and many of the patients of sleep apnea are not detected. This is an outpatient clinic of sleep apnea patient. All of them could have sleep apnea. And just mentioned before that it's not the stereotype of an obese patient. We all see patients who are not that obese and still they have sleep apnea. The patient with diabetes and overweight, hypertension, resistant hypertension, post-stroke, all might be. Now this is one of the useful questionnaire that we might teach to the physicians, just to ask them and then to detect sleep apnea just by questionnaire, and then to refer them to do pulse for later. Now, talking about the cardiovascular complications, there's a paper from cardiology. Now, this is from the American Heart Association. Others have been interested in sleep apnea. This is what we are doing, is making other specialties rather than pulmonary and neurology aware of what sleep apnea, because patients are referred to them rather than pulmonologists. They go to the people with resistant hypertension and cardio-resistant heart failure, fibrillation, and so on, rather than coming to us. Now, this is also been shown that if you have snoring and sleepiness, so your survival, the risk of cardiovascular disease will increase. And this is an old study showing that the patients who have been given tracheostomy, and this was the only treatment at that time for sleep apnea, will have less proportion without cardiovascular events. So they have tracheostomy, the cardiovascular events will decrease. And this is a very old study also showing that the effect of snoring, prevalence of hypertension is more in the patients who are snoring, just by asking about snoring. Now this is a 12-year study follow-up with the patient showing the cardiovascular sequence, whether fatal or non-fatal, and showing that if severe obstructive sleep apnea, you will collect more points when you pass over the years. And interestingly, if the patient is receiving a severe obstructive sleep apnea and receiving CPAP, so he will have his incidence of cardiovascular events, fatal or non-fatal, will come down over the years. So this makes the sleep apnea, it will cause a fatal, will cause a cardiovascular events, and it's a primary prevention. If you give the patient with CPAP from the start, or sleep CPAP from the start, it's a primary prevention, as we ask, for example, the patient with diabetes to take aspirin to prevent cardiovascular event. So it's in giving this disease will prevent them from going into such complications. This is also an old study showing the increased mortality among sleep snorers. Also, this is the effect of sleep apnea mortality is according to the severity. If you have more than apnea index more than 20 or less than 20. Again, this has been shown by Professor Safwan, and this is the effect of survival. And it's interesting, if the patients are using it, this is a comparison between the patients who are using the CPAP or not using the CPAP, and showing that the patients who are using CPAP are having a better survival than the portion of severe sleep apnea or not using the CPAP. Now, this shows that when years has passed, if you have a very severe sleep apnea, you have more instances of hypertension, of non-dipping during sleep, and this is a manifestation of early manifestation of hypertension, increased depression, and increased stroke, and all-over mortality will increase with the sleep apnea. This survival in women with obstructive sleep apnea with treatment status, and this again showing the community mortality increasing with the patients who are sleeping, who are apnea hypopnea, are not using the CPAP and still have a high degree of sleep apnea. Now this is a recent study from Australia showing there's a sleep apnea over 20 years, just been published recently in Clinical Journal Sleep Medicine. A community-based cohort study over 400 residents of Western Australian town, and showing the mortality, all-cause mortality and effect on the severity of sleep apnea on the coronaries and the heart failure and others. Now this shows that the all-cause mortality here, the patient's sleep apnea, severe sleep apnea, the cumulative number of deaths is higher among the patient's sleep apnea compared to the mild sleep apnea. If we talk about this is all mortality. The incidence of cardiovascular disease in the coronary heart disease was very astonishingly, or I don't know, there should be explanation for that the coronary artery disease was not statistically higher in the patient with sleep apnea, severe sleep apnea. And even the moderate degree of sleep apnea, they showed that the odds ratio was less than 1. However, looking at stroke, there was increasing in the severity of the stroke, and the stroke and it was higher across the patient. The cumulative number of hospitalization death from stroke was increasing with severity of obstructive sleep apnea. If you look at the coronary heart disease, this was said that it is not statistically higher among these patients. So if you haven't, this is coming with the cancer mortality, which is, they looked at the incidence of cancer mortality, and this is another thing which is people are talking about now, that the patients with sleep apnea are having a higher incidence of cancer and high incidence of cancer death. And if you look at the moderate to severe, the cancer mortality, it's 3.9, that's 4 times more than the usual population, and the cancer incidence and the non-skin cancer, you could see the numbers increasing with the patient with moderate severe sleep apnea. Now, association with sleep apnea and cardiovascular disease, there's a lot of fears going on, inflammation, oxidative stress, sympathetic activity, and others, leading to the association to sleep apnea and cardiovascular sequencing. Now, this is a very important figure showing how these patients are prematurely dying from sleep apnea. And if you go, this is a sleep study, as you all know, and showing here that this is an apnea, obstructive apnea. There's still abdominal and respiratory movement, and this is an apnea, and this is desaturation. And you see that the heart rate is slowing down until it goes into a sign of atrial block, where the heart stops. And if the patient didn't have this arousal and ECG comes kicking again, the patient might die prematurely at a sudden cardiac death, which most of these patients die during their sleep due to lack of arousals at one dark time of their lives. And you see that sudden cardiac death in the incidence in the general population usually comes between the 6 a.m. and 12 p.m. However, if the patient having sleep apnea, the sudden cardiac death will occur between midnight and 6 a.m., which is the time of sleep apnea. Now, and this is a different association between the timing of the start of acute myocardial infarction and the time of sudden cardiac death, different from the general population from this sleep apnea. Now, subclinical coronary artery disease, and this is very common to be detected in the patient's sleep apnea, although the study that just mentioned that it didn't increase the severity. This is a study showing 160 consecutive patients, and most of them had presented acute coronary syndrome, and the prevalence of sleep apnea in acute coronary syndrome was about 40% in male and 35% in female. So it's very common to have, if you would detect, if you study acute coronary syndrome, and we will find very high incidence of sleep apnea in such patients. And this is the daytime pattern of myocardial infarction. They said it starts with myocardial infarction, different from the general population, starting in the daytime, during nighttime rather than the daytime. Arrhythmia and obstructive sleep apnea, and most of these patients have much arrhythmias. As you see, this study is 228 subjects. Those with severe sleep rate breathing disorders have risk of nocturnal complex arrhythmia. And we have a study here in Alexandria, Victoria Natural did a study before showing the Holter monitoring and showing all kinds of arrhythmia, and these all arrhythmias have been reverted after 3 months of using CPAP. Now this is from this is shown that the odds ratio for the patients having for arrhythmia, just for age, sex, and body mass index to coronary heart disease, non-sustained tachycardia 3 times, and the atrial fibrillation about 4 times. And the association between atrial fibrillation is obstructive apnea due to hypoxemia, sympathetic activation, extreme blood pressure surge, and transmural pressure and systemic inflammation. And this is also before the tracheostomy, 20% of the patients with sleep apnea have atrial fibrillation, and after 6 months of tracheostomy, all this atrial fibrillation just disappears. And the incidence of atrial fibrillation by obstructive sleep apnea status, if you have sleep apnea, you have more incidence of going into atrial fibrillation, and this differs according to the severity of the disease. Now, if you go to a cardiology department, you find that 32% of the patients in the cardiology department have obstructive sleep apnea. If we lump together the patient with atrial fibrillation only, we'll find half of them, about 49% of them, are suffering from atrial fibrillation. Also, there's a relation to the recurrence of atrial fibrillation, and this is untreated obstructive apnea showing a high incidence of recurrence of atrial fibrillation. Now, this is a PubMed study done recently in 2014, again on 1,298 articles, a meta-analysis excluding already edited reviews, and concluded that arrhythmia is very frequent obstructive apnea, and the treatment of obstructive apnea may reduce some of them, and maybe should put an implantable cardiovascular defibrillator together with the CPAP in treating such patients. Now, this is a paper done by Dr. Nashwa here from Alexandria on the tachyarrhythmia in the Egyptian patient with tachyarrhythmia. And the aim of such a work was to study a potential independent relationship between sleep-breathing disorders and tachyarrhythmia. And they studied 32 patients coming from tachyarrhythmia, diagnosed based on current American College of Cardiology and other criteria, and excluding patients with valvular heart disease and left ventricular ejection fraction, chronic lung disease, hyperthyroidism, and others. And they found that 17 of these 32 patients had atrial fibrillation, 8 had PVC, 5 sinus tachycardia, and 3 of them having supraventricular tachycardia. And when they started to divide these patients, they found that the patient with severe sleep apnea are most of the patients of, we found that most of these patients present with arrhythmia have a severe degree of obstructive sleep apnea. And they did the regression analysis for that time, for all of these, and they found that the model included the 3 variables: BMI, neck circumference, and serum triglycerides, yielded the highest predictive value, suggesting that patients with arrhythmia who have high BMI, neck circumference, triglycerides are more likely to have an underlying obstructive sleep apnea. Now, this is again in relation to the cancer mortality, and I'm not talking about that. Now we know syndrome Z, which are the people who are obese and having hypertension, insulin-resistant dyslipidemia, and of course syndrome X, and add to that obstructive apnea, this is syndrome Z. And thus we come here to the relation between the hypertension and sleep apnea. And this is a very illustrative figure showing that the patient, when they go to absence of flow and they desaturate, they have a large surge of the blood pressure. The patient goes to sleep with 120 over 60 blood pressure, and they come to 220 over 120 when this airflow limitation has been there for a long time. So there's no pill that can reduce the blood pressure in such a patient, which is only caused by the obstruction. And the presence of non-dipping might be a marker in the sleep study for these patients, even if they don't have a daytime hypertension, that they are patients with sleep apnea. And this is an old study from Professor A.D. Williams, which I have the pleasure to work with him in the United States at some time. And he had 23 patients taking antihypertensive medications at random, and the patients who have significant arterial oxygen saturation observed in about 30% of the patients with an average 87% at the end of the apnea episode. And this is all study showing that obstructing the larynx of the dog for several times would make this dog hypertensive after some time. And if you remove this plug from the dog, there is a reversal of the obstructive sleep apnea. This is a long Wisconsin sleep study showed consistent obstructive apnea blood pressure dose-response relationship, and this showed the odds ratio. If you have more than 30 apnea hypopnea index, you have more chance of having hypertension. And this is it might be the inflammation, systemic inflammation behind sitting behind the hypertension in relation to the sleep apnea and hypertension. This showed the CRP was much higher in the patients with obstructive apnea rather than the control. The carotid intimate thickness might be a marker for the atherosclerosis occurring in the sleep apnea, and this is many of the studies showing again there's a relationship between the carotid thickness and the sleep apnea. The relationship of systemic hypertension and sleep apnea might be due to heightened sympathetic activity, abnormal vascular activity, and down-regulation of the sympathogenic receptor or nitric oxide. This is a study which is done in Alexandria by myself and my colleagues there, and Eva Harraf and Sami Atta and Dr. Kofi and Manshar Awi and others. And this showing we took 150 patients with sleep apnea, and then we 150 patients with hypertension, and they started to divide these patients doing studies for all these 150 patients, and started to specify how many of them have sleep apnea and how many they didn't. And then we stratified this patient to patient with essential controlled hypertension with sleep apnea, essential controlled hypertension without sleep apnea, uncontrolled hypertension, and uncontrolled hypertension without sleep apnea and heart. Now, we started the brachial artery analysis of these patients and showed that these patients who have a flow-mediated sleep apnea have a bad flow-mediated dilatation of the brachial artery. If you close the brachial artery in the southern region, the flow-mediated release will be less in the patient with sleep apnea. And in the third independent vasodilatation, when we give nitroglycerin to them, again, the response to the patient who would have sleep apnea was less than the others. So this would show that there's a problem with vascular activity in such patients. Finally, the nitric oxide, and we find, we also in this study showed that the nitric oxide has been low in the patient with controlled hypertension and obstructive sleep apnea, and uncontrolled hypertension with sleep apnea, and even in the patient with obstructive sleep apnea who didn't have hypertension, will have a low serum nitrate. This might be a pre-hypertensive state in such patients. Now, again, we started, if you are talking about nitric oxide, we studied the effect of the endothelin, or the study of the levels of endothelin in such patients. This is a study that is done also by Dr. Natra from Alexandria again, showing the non-dipping pattern of nocturnal blood pressure and obstructive sleep apnea and the role of oxidative stress in output. And in this study, about 84% of the patients with obstructive sleep apnea shown again that there is endothelin 1 was high in the patient with sleep apnea and more oxidative stress in such patients. This is also the prevalence of obstructive sleep apnea and resistant hypertension, and this again we found in about 82% of the patients coming with resistant hypertension. They are taking 3 drugs or more and they are not having control of hypertension. We found that this population, about 80% of our patients have resistant hypertension. And this again from Alexandria study. I will not talk about the effect of CPAP. Dr. Natra, I think, will continue about.
I would like to thank Dr. Loza and the organizers for these great events and to invite me to be here among the great professors in sleep medicine. As you know, CPAP is the most successful treatment for sleep apnea up till now. It acts, as Dr. Safwan mentioned, as pneumatic strength. It opens the upper airway. It's just a blower. And one patient told Dr. Mahmoud when he astonished by the price of the CPAP, I can turn a vacuum cleaner to CPAP. It's just a blower that applies high pressure to the upper airway to keep them cleaner. When abolishing sleep apnea by CPAP, treatment will affect the quality of life and all modifiable factors like cardiovascular diseases. As we know, sleep apnea affects cardiovascular system by repetitive arousals, which increase sympathetic charge and hypoxemia and change in intratheretic pressure. CPAP could convert these effects. This is 5 minutes epoch of sleep study of patient admitted to the ICU by hypertensive encephalopathy. Sleep study was performed to him, and as we've seen, repetitive apneas is shown in these 5 minutes, associated with repetitive desaturation, resaturation, and repetitive decrease and increase in heart rate, and repetitive increase in systolic and diastolic blood pressure. Sympathovagal balance was assisted by change in heart rate variability, and we find that sympathovagal balance increased during the apnea's attack. This patient before sleep, his blood pressure was 190/120, and during the night of sleep study, his average systolic blood pressure was 190 over 125. This means that no dipping in his blood pressure occurred during that night. The next night, the patient used CPAP and sleep study repeated for him. As we see, no apneas or hypopneas at all. And the blood pressure is regulated, no surge in systolic blood pressure at all, nor diastolic blood pressure. His blood pressure before sleep was 170 over 100, and during sleep his average blood pressure was 152. This means that dipping starts to restore in the first night of using CPAP. In a study conducted in Alexandria, we found that the level of dipping in blood pressure was inversely correlated with the arousal index. That repetitive arousal with the increase in sympathetic charge is the main cause of occurrence of non-dipping. In 1995, we started MD thesis in evaluation of effect of CPAP on patients with obstructive sleep apnea, conducted on 24 patients. We find that 62% of them were hypertensive, and when we estimated the diurnal and nocturnal urinary norepinephrine, we found that they are correlated directly with the systolic and diastolic blood pressure. After using CPAP for 3 months, we found that both systolic and diastolic blood pressure decreased significantly after using CPAP. Also, diurnal and nocturnal urinary norepinephrine decreased significantly after using CPAP. A recent meta-analysis in 2014 found that using CPAP have significant effect on hypertension. All the studies except one of the studied papers are with the decrease of mean diastolic and systolic blood pressure with CPAP. All favors using of CPAP to reduce blood pressure. Also, CPAP caused decrease in the 24-hour systolic blood pressure and diastolic blood pressure and mean arterial blood pressure. All papers in favor of decreasing blood pressure while using CPAP. Also, daytime systolic blood pressure and nighttime systolic and diastolic blood pressure decreased markedly with using CPAP. Nighttime mean arterial blood pressure and daytime also decreased on CPAP. Another meta-analysis studying the effect of using CPAP on the level of inflammatory markers found that using CPAP affect markedly the level of C-reactive protein, tumor necrosis factor, and interleukin-6, all in favor with decrease in using CPAP except interleukin-6. Another cardiovascular consequence is the arrhythmia. Again, the same patient, when we look to his 5 minutes epoch, we find that with repetitive apneas, the heart rate decreased markedly during the apnea and increased with the termination of the apnea. That's what's called brady-tachyarrhythmia, which is characteristic for sleep apnea. The same patient, when used CPAP, there is no change in his pulse during the night on CPAP. There is no brady-tachyarrhythmia. Other arrhythmias found to be found in patients with sleep apnea in the study conducted on 24 patients are supraventricular and ventricular tachyarrhythmias. Regarding the minimal pulse rate and maximal pulse rate and average heart rate, all improved on using CPAP for 3 months. The minimal heart rate increased and the maximal heart rate decreased, as the brady-tachyarrhythmia decreased, and also the average heart rate decreased significantly after using CPAP. All supraventricular and ventricular ectopics disappeared completely on using CPAP. Sleep apnea affects atrial fibrillation by hypoxemia, sympathetic activation, increase in blood pressure, transmural pressure gradient, and systemic inflammation. All these factors are converted by using CPAP. So the use of CPAP, as Dr. Mahmoud and Dr. Safwan mentioned, improve the risk factor for fatal and non-fatal cardiovascular events in patients with sleep apnea. Regarding pulmonary hypertension, it's found to be increased in sleep apnea and decreased markedly while using CPAP. In the study conducted on 24 patients, we found that both ejection time, acceleration time are decreased after using CPAP. Sorry, acceleration time increased and ejection time increased after using CPAP for 3 months. This means improvement of the systolic heart functions and improvement of pulmonary hypertension. This is sleep study for a child who is 7 years and presented with Prader-Willi syndrome and severe pulmonary hypertension. His acceleration time decreased from 88 to 66 on 2 years. When he performed a sleep study, we found that he has sawtooth appearance in the oximeter with hypoventilation. This means that he has hypoventilation and obstructive sleep apnea. His apnea-hypopnea index was 41.7. While after using CPAP for 3 months and repeated echocardiography, his acceleration time increased to 101.8. That means improvement in his pulmonary artery pressure. Thank you very much.
Thank you very much, Professor Mood and Professor Nashwa, for the very nice, informative presentations reflecting how far the cardiovascular system is affected with obstructive sleep apnea. Now the floor is open for discussion. May I invite Professor Safwan Badr and Professor Nashwa. Professor Mahmoud is here. Please come. Be ready to answer if you can.
Okay.
Any question from the floor?
Epidemiology or disease? That's actually a wonderful question. I've never been asked this one before, but I can give it a try and see what other people think. It's maybe all. I suspect it's all. So I can, let me start by every one of them. The disease we know, okay, it's a disorder, it's a disease with consequences. I think that part is established. I would take it a step further and say, is there something underlying this anthropology and epidemiology that may increase the propensity to develop sleep apnea? Why is it that people 200 years ago have the same amount of sleep apnea that we have today? So there are two ways. So let's start with anthropology. One of the things we know is that there are differences in the prevalence of the disease in different parts of the world independent of body weight. So for example, the East Asia population tend to have more sleep disorder breathing. And we see actually young men who are thin and otherwise healthy who have it. And probably this may be related to facial structure, to bony structures. So we talk about a flat face, a brachycephaly, and it's actually a real possibility. So that's one that is entirely related to geography. That's one. Epidemiology, we do know that environmental changes do affect disease. For example, young African American males in the United States have the higher prevalence of sleep apnea than any other group and have worse consequences. Well, now I don't know what the corollary is if we cross the Atlantic to go to West Africa. But clearly there are changes. They also have the highest rate of high blood pressure, independent of anything else. So that are epidemiologic environmental changes. In the United States, the change in the obesity rate clearly changed the disease. So that's another emerging one. How do all of these things interact together with culture and lifestyle and sleep deprivation, if I may add? That's another factor. At the end of the day, we're all reaching that there is a disease. The threshold is maybe what's different. I suspect the disease is actually increasing because of all of these factors together. I don't know if that answers your question.
Yeah, actually, this question popped to my mind when I saw Michigan, Detroit, Michigan, having the highest obesity rate. So I think it's small matter.
Actually, we are not the highest obesity rate. There are others.
It's more orange.
If I just may add a comment to the anthropology and to the question. Definitely, as there is a change in the obesity, there is a change in feeding the babies as well, from the breastfeeding to the bottle feeding. Even with the natural, in the US, we tend to have the ladies pump the breast and get the milk in bottles. It's still the natural milk, and mothers still think that they're doing the good feeding. But the bottle itself, the way the baby sucks on the bottle and the way the baby sucks on the mother's nipple is different, and it changes the anatomy of the baby as they grow. I tend to see more of a children population and a teenager population, and the majority of them, I notice that they have a higher arch palate. So that's definitely related. The pacifier that's given to children also changes the anatomy as a child grows. The child who suck the thumb also have a tendency to have a higher arch palate. So there is definitely a change in the evolution of the way the old man shaped and the society that we live now, and the tendency to rely on faster things. Thank you.
Any other question? May I start by one until you prepare yourself? My question is to Professor Mahmoud about sometimes you are asked by one sleep apnea patients on CPAP. Yes. The patient doesn't have any family history of hypertension, but he developed the hypertension after the sleep apnea. After CPAP, you are expecting that this patient will omit the antihypertensive medication or he will continue.
I think the study has shown that particular patient with resistant hypertension, while using 3 drugs, including a diuretic to the maximum dose, and they are resistant hypertension, for instance, about 80% of them having severe obstructive apnea, simple sleep apnea, will come down, as the studies have shown, to 1 or 2 drugs instead of using 3 drugs. Rarely they might need the drug at all completely, but at least they can downsize the regimen of antihypertensive drug. And this is shown by the studies, as I have read.
Not stop.
Increase. Increase.
Just to add to Professor Mahmoud, I think that hypertension, when it is developed as a disease, there is a pathology behind this, and it's multifactorial pathology. Hypertension is not just something historical. We are talking about the changes in the remodeling in the vessels, and that's why we expect that just CPAP will solve the problem. The pathology happened, and this, even if obstructive sleep apnea is the cause of this pathology, but the pathology is settled there. So I think it's not that just using antihypertensive will finish the problem.
Because that's the question, whether sleep apnea is aggravating an already present pathology or it causes. So it's other perpetuating factors. The pathology is there, but sleep apnea makes the pathology clear, or it is the sleep apnea which does the pathology.
If I may add, I think the Joint Committee for Studying Blood Pressure has added obstructive sleep apnea as a cause, which
I might add to this. Obstructive sleep apnea, as we've shown, the pathology itself, the pathogenesis is sort of intermittent ischemia and sedation. This will start with atherosclerosis with many compounding factors, blood gas index and the age and the sex and so on, and all this will come down to atherosclerosis. I think CPAP is one of the. It's very difficult to take it out as a lone factor causing all this. So it's a combination of all of them. And the studies are very difficult to construct to just make the sleep apnea stand alone as a cause. It's surely it's a very one of the pathogenic factors for development of atherosclerosis.
To follow up on what Dr. Shahira mentioned, the Wisconsin Sleep Cohort Study had a longitudinal study where they followed up patients. So there were incident hypertension. So there would be some patients who don't have hypertension on point A, and 4 or 5 years later, if they have sleep apnea, will have more hypertension than those who don't have sleep apnea. So clearly, at least, and this is where things are pretty multifactorial, there is a subset where sleep apnea could be a causative factor.
I have two questions, one for Professor Safwan, about the role or the effect of obstructive sleep apnea on the renal disease or the renal patient. What is the effect on the diabetes, maybe fluctuation or raising of the blood sugar and hypertension, raising of the hypertension? What is the effect on the venous?
Well, I think the buzzword now, which I don't know if this is specific for renal function per se, is chronic intermittent hypoxia. So with chronic intermittent hypoxia, there is worsening in, there's insulin resistance with all of its consequences. There is increase in blood pressure, increase in the sympathetic. I don't know specifically what effect there would be on the GFR. But I think it's most of the effect is indirect through changes on cardiovascular control or blood pressure.
Affecting the blood pressure.
Right, I think that's probably the main. But patients who have end-stage renal disease, that by itself could cause sleep apnea. So now the relationship is bidirectional because now you have fluid retention. You're right, because at that point you have two things. One, you have changes in ventilatory control, electrolyte changes. And two, there's actually increased body fluid. And total, basically, vascular volume is higher. And there's some very interesting work from Doug Bradley in Toronto when they showed that just assuming the supine position brings all this fluid that has accumulated, the caudal return of fluid. And you actually measure neck circumference and it increases. So there is a significant effect on just vascular volume.
About the effect of obstructive sleep apnea on hypertension. Hypertension patient when needs 4 or 3 drugs, sometimes it may be reduced the amount of drugs when you use CPAP and treated the effect of obstructive sleep apnea. But sometimes other patients, which include the non-livers, there is no elevation in blood pressure. The blood pressure 120/80. But during polysomnographic study, they are raising the blood pressure recording 190/110. How we can add treatment for those patients? Dr. Nashman?
I think these patients is significant for them. As the blood pressure increased due to the acute effect of the sleep apnea itself. So abolishing the sleep apnea will reduce the blood pressure. As they are not chronic hypertensive, they have no diurnal time hypertension. So if we treat sleep apnea, this will affect their blood pressure. But if they have diurnal hypertension, at this time they need treatment for hypertension.
I agree fully. I mean, I think if there's no evidence that they have daytime hypertension, treating sleep apnea becomes, treatment of the sleep apnea should be sufficient. Because now we're talking about the acute cardiovascular consequences.
Any other question?
I have a question to Dr. Mahmoud about the predictors of sleep apnea equation using BMI, triglyceride, and neck circumference. Is it possible to use it in all cases or just in cases with arrhythmia?
Well, just this was a finding from a single study. I mean, when we did the regression analysis approach.
Sleep study was performed on patients with tachyarrhythmia, and only this group of patients we find that tachyarrhythmia associated with sleep apnea more if there's increase in triglyceride and body mass index. But there's no meta-analysis regarding other prediction factors. regarding the renal failure, end-stage renal disease, we performed a study on patients with end-stage renal disease. We find that patients on hemodialysis, the day after dialysis, the apnea-hypopnea index decreased than the day before dialysis. This means that end-stage renal disease has special characteristics, sleep apnea different than other populations. And some authors recorded that nocturnal hemodialysis may improve sleep apnea.
That's correct, and that's exactly how it works.
Any other questions? Please.
What is the effect of using CPAP or BiPAP or the coronary blood flow? I mean, it's
Coronary blood flow?
The acute ischemia is contraindicated. Better to use BiPAP better than CPAP.
Yeah, there have been more studies showing that the swing to the BiPAP might hamper the coronary blood flow. CPAP, the continuous flow, the pressure, might be more beneficial in the patient. These have studies on the acute pulmonary edema, using CPAP and BiPAP in the acute pulmonary edema. So they show that the BiPAP might worsen the ischemia in such patients. But only all studies that I remember. I don't know about new studies. Sure. Using of CPAP or BiPAP in acute coronary syndrome, in acute pulmonary edema.
في الأكيوت pulmonary edema mostly احنا we're looking at the CPAP or the EPAP هو اللي بيعمل المور effect. إلا إذا كان مع الأكيوت pulmonary edema لو في chronic يعني في acute respiratory failure و PCO2 عالي most of the data اللي عندنا اللي هي على use of non-invasive ventilations in these patients are usually with the COPD exacerbations. But sometimes we extrapolate the data to the acute pulmonary edema too. But in most of the cases, we use a CPAP.
In cardiac patients, not in pulmonary. In cardiac, coronary flow.
In the cardiac patient, are you referring to the Canadian study that was terminated earlier, the CANBAP, or because I'm not clear about the question?
What is that? Better to use BiPAP better than CPAP or acute ischemia, acute coronary ischemia. In my patient has acute coronary ischemia and heart failure. Better to avoid using both BiPAP and CPAP or.
The question is whether there is contraindication for the CPAP or BiPAP in acute coronary syndrome.
There is no contraindication to use the CPAP or the BiPAP. It is all going to depend on the ejection fraction and the medication that's being used and the cardiac output and the optimal pressure. So if you are using a lot of CPAP and you're decreasing the venous return, definitely you're going to increase the risk of these patients.
Doesn't affect the coronary blood flow.
It will affect the coronary blood flow. Yeah. Dr. Badr, do you have any comment on that?
Well, I mean, what matters here is the mean airway pressure. So I don't think whether it's CPAP or BPAP is the issue, and I tend to use the word BPAP as opposed to BiPAP because that's a brand name, and because then you can cut across all the systems. One of the things we know, and really you can titrate this from a study. So I agree with you. I don't think it makes much of a difference. Any positive pressure, if somebody decreases afterwards. So it really doesn't matter whether it's CPAP or BPAP, as long as you use the minimum required, the absolute minimum required. Now there is one point of caution with BPAP as a mode in patients who have central apnea. You may actually aggravate their central apnea and induce periodic breathing. So if you look at the recommendations for the treatment of central apnea, BPAP without a backup rate is not recommended. You will induce periodic breathing. And so as a starting point, I always want to start with CPAP and then go to BPAP if needed.
Instead of consuming the time on this topic, I will try to address it in the lecture on the CPAP and PAP therapy.
I think now we reached our time, and before closing, I want to thank all the speakers for a very stimulating and interesting session. And we will have, I think, first here a 15 minutes break.
Again, thank you all for being there. Thank you all for the audience for being there. We have a quarter of an hour. We start again the next session as we're running a little bit late. I also encourage you to visit the exhibition hall, to visit the society booth, and to fill up a form to become a website. Thank you very much.